Olá e bem-vindo a mais um Global Summit e, neste caso, ao Einstein Talks, uma oportunidade para nós falarmos ainda um pouco mais sobre os benefícios da telemedicina e como nós, há 8 anos, numa visão de futuro, vislumbramos o papel que a telemedicina teria e está tendo no rompimento das barreiras logísticas para que a gente possa levar melhor saúde de forma mais próxima, com maior acesso à população a essas plataformas. Talvez aqui, dentro do Einstein Talks, seja uma grande oportunidade, e dentro do Global Summit, de nós discutirmos os papéis de cada um dos nossos profissionais, sejam médicos, sejam profissionais de saúde, às custas de atendimento com telemedicina, mas também discutirmos aspectos regulatórios para que a telemedicina seja entregue da melhor maneira possível, com qualidade, com rigor, com um benefício que transcende muito aquilo que se critica como perda de humanismo, aquilo que se critica como uma eventual complicação ou uma falta de reconhecimento de uma condição de saúde à distância. Muito pelo contrário, nós temos hoje uma evolução em termos tecnológicos, em termos de capacitação profissional, praticamente uma nova escola de como é o comportamento e o entendimento dos limites, das fronteiras, tanto do profissional de saúde quanto por parte do paciente, acerca do atendimento feito por teleatendimento, por teleconsulta, por teleconferência, por teleinteração. É esse o papel da telemedicina. Portanto, eu os convido a, neste momento, criarem todo o ambiente para discussões profícuas, para retirada de dúvidas, para sugestões, para aprimoramento, enfim, para uma interação que possa trazer à tona o melhor benefício que o teleatendimento e a teleinteração pode trazer no âmbito do atendimento, do diagnóstico, da saúde da nossa população. Participe, a nossa discussão ela é importantíssima, não apenas aqui dentro, mas para influenciar outras organizações, políticas, regulações, acreditações, certificações, enfim, trazer nesta forma um ganho enorme para a nossa população em termos de cuidado à saúde. Um abraço a cada um de vocês e que seja um evento maravilhoso.
Hello, this is Peter Antall. I'm just preparing to start my session. It's Peter Antall from the United States, AmWell and AmWell Medical Group. Let me just go ahead and share my screen or share my slides, and I'll go ahead and get started. Hello. Hi, my name is Peter Antall. I'm a physician in the US, and I'm the president of the AmWell Medical Group, as well as the chief medical officer of AmWell. So I'll talk a little bit today about telehealth in the age of COVID, and I'm going to share some of the learnings from our company and our experiences going through the last few years and as well going through COVID. So who is AmWell? AmWell is a leading U.S. telehealth organization. We support many entities in their telehealth efforts, including software support and hardware support and a variety of miscellaneous and related telehealth services. We also, as I'll mention in a moment, have our own telehealth medical group. What does that mean? Well, as you can see on the screen, there's a variety of potential offerings. AmWell really began as a software provider. We created an ecosystem, a software ecosystem that allowed patients and providers to meet for meaningful telehealth visits. We also solve for a lot of the regulatory and legal challenges, the privacy and other things associated with having those types of encounters. Over time, we've built out kiosks. We've acquired companies in the acute care cart business. So carts in the emergency room or on the inpatient wards of hospitals. We've also built out a number of integrations and affiliations with various companies in the data and device space. So wearables and items that bring data into an encounter. The vision with AmWell is that we can interact from anywhere to anywhere. Now, who do we serve? In the US, we serve a number of different types of companies that are involved in the healthcare ecosystem. So health plans or insurance companies. You can see a number of very large ones, including Anthem and United Healthcare. Employers, a number of employers in the United States offer added health services to their employees. Health systems, so the big, well-known health systems and hospital systems like New York Presbyterian and Cleveland Clinic and Intermountain. And then finally, more traditional retail and technology companies, so health tech companies, Medtronic, Philips, Cerner, the EMR operator, and retail, a variety of pharmacies and grocery stores and other non-healthcare entities like Apple and Google. All are our clients. So what is it about? It's about interactions that are delightful and simple and seamless. In this example, a patient is inquiring about a visit with Intermountain Healthcare in the west of the US on a simple home-based device, an Apple MacBook. This is the workflow that allows the patient to begin and initiate a visit. In the end, what results is usually a live, synchronous audio-video interaction. It's an interaction that is very personable. You can see each other, the facial mannerisms. You can communicate together. You can point to things. And importantly, in healthcare, you can examine the body in many ways. This particular visual also shows that we can do more than just interaction between a provider and a patient, but we can bring in other important parties, other clinicians to be part of the healthcare team, and even family members. So the patient might bring in an adult family member who is helping with their care. Now, we also have a medical group in the United States. So we provide services throughout the 50 states. We provide a number of clinical services, and these services are really there to support AmWell clients and as well patients interested in care outside of traditional healthcare. So what does that mean? Some of our programs involve physicians for urgent care, sleep, psychiatry, virtual primary care, which I'll speak about a little later, other provider types, dietitians for nutrition advice, lactation consultants for help with breastfeeding, nurses and other care providers like therapists that provide meaningful care. So I want to talk a little bit about the experience, and I'm going to start prior to COVID, prior to this year. So back in 2017, a very well-known, internationally known cardiologist and futurist, Dr. Eric Topol, made a bold prediction. He predicted that by the year 2024, in the US, there would be an equal number of telehealth visits as there are in-person clinic or office visits. Now, at that time, many scoffed at that prediction. But as you'll see, with COVID, that may have been too conservative. We may see that crossover point occur well before 2024. From 2015 to 2019, adoption by providers began to really increase. Now, back in 2015, telehealth was really a side project. Only about 5% of US physicians had ever used telehealth to see patients. But by 2019, 22% had now used telehealth. That's still modest. That's not yet a quarter of the providers, yet it was the beginning of a revolution. What we would call this in other settings is the early adopter phase of technology adoption. Now I'm going to talk about what happened when COVID hit and the impact on telehealth. So going back to that last slide, from 5% of providers in 2015 to 22% in 2019. In 2020, there was an explosion. Providers needed a way to care for their patients. Their offices were closed. Patients were afraid to go to healthcare settings for fear of catching COVID. By the middle of 2020, according to our physician survey, now a complete change. 80% of US providers had used telehealth to see their patients. What a remarkable change. And it took a pandemic to really cause this to occur. This is a slide about that shows our patient volumes over the last 5 years. You can see back in 2015, volume of visits was quite modest or small. By 2016, it began to increase, and each year, these increases were often a doubling or even a tripling, but they were still modest. In 2020, everything changed. We all of a sudden saw a 9 times increase in patient visits over a very short period of about a month. That's 900% increase in patient volume. We also saw changes in consumer behavior. Consumers using telehealth for the first time. We saw on our platforms a real change from 55% of visits being a first-time patient to 75%. So many patients who have never tried telehealth were now using it for their healthcare, either for acute problems or chronic problems or other needs. We also saw, as we looked on Google, a massive spike in searches for the keyword telehealth. So patients were going onto Google looking for telehealth, trying to figure out how they could receive care in the age of COVID. The viral pandemic has been followed on very closely by a new epidemic. An epidemic of mental health disorders. This is particularly a problem in the United States, as it certainly is throughout the world. In the United States, according to the Kaiser Family Foundation, in July of 2020, at that point, 40.1% of US adults reported symptoms of depression or anxiety. So almost nearly half of US adults were having signs of mental health stress or disease. So I want to shift and talk a little bit about how did we do it? How did we respond to the COVID epidemic here in the US, or pandemic? So this is data around our urgent care offering, and this is national US data. In our urgent care offering with our providers, 8 to 12% of patients in the period from March through July of 2020 came for care related to COVID. Of those 8 to 12% of patients, 93% of those patients had stable COVID-like illness. 7% of those patients had unstable COVID-like illness. They were seriously ill, and I'll talk about and define that in a moment. In terms of states, I wouldn't expect anyone out of the US to recognize these shapes, but these represent 3 of our states. This is Florida, New Jersey, and Texas. These were the states with the most unstable COVID cases over that time period. This slide represents how we risk stratified patients presenting with respiratory disease. This was, again, during that same period from February through July, although we continue to use this methodology today. On the left, in the red box, we see COVID-like illness unstable. I mentioned this a moment ago, 7%. These are patients who were very ill. These are patients who were gasping for breath or having severe respiratory distress, severe chest pain, dizziness, loss of consciousness. These were patients that we immediately sent to the emergency department. The next box in the salmon color was COVID-like illness stable, but with complicating factors. The term stable, we meant to mean clinically stable and not in need of emergency care. These were patients that presented with symptoms suggestive of COVID or COVID-like illness. However, they were not having any symptoms that required immediate in-person intervention. They were breathing comfortably, they were eating okay, etc. However, these were patients that exhibited signs themselves or had family members in the home that had signs or diagnoses that made them high risk. These were patients with obesity and diabetes and hypertension and immune deficiency. So these were patients that were considered high risk for severe COVID disease. In this group, we evaluated these patients. We made home care recommendations for ongoing management, and we did prioritize these patients for testing for COVID. These were patients we sent for nasal swabbing testing for COVID because that testing might change the management, increase isolation, etc. In the middle box, COVID-like illness stable. These were patients that met criteria for COVID-like illness, but had no pre-existing risk factors for severe COVID disease. These were patients for whom we recommended self-isolation and routine infection control, but home care for now. On the right of the screen in the yellow box, low-risk patients. These were patients that had respiratory disease, but appeared unlikely to have COVID. These were patients who we recommended simple measures like self-isolation for a short period, home care, and routine infection control measures. And finally, the box in green on the right, these were patients that showed no evidence of any significant disease. No COVID, no influenza, unlikely to have any significant conditions. Often these were patients that we called worried well, meaning they were scared about COVID, but did not appear to have any diagnosable illness. How did we mobilize to address the pandemic? Well, we needed all hands on deck at this moment, as did most of the world. For our purposes, as clinic settings in the US were closing due to COVID, we saw that massive increase in volume, so we really needed to respond a large amount of physician availability. So we optimized our existing group, our existing network. We reached out to each clinician, asked for more hours, tried to get them re-engaged if they had not been active with us so that we could get more volume, more supply of providers immediately. We grew new provider supply. That means we went out and actively recruited for physicians to come on and join our group and get involved in COVID care. And finally, we streamlined our onboarding, our training, our support to make it as easy as possible for providers to become active and available to see patients on our network. So where are we going? What's next? This is the exciting part. Telehealth is evolving before our eyes. One of the themes that we're seeing is a move from transaction one-time visits to continuous digital care, longitudinal care, or what we call in the US continuity-based care. What does that mean? That means a known provider who can see me regularly and can follow up on my clinical needs. And in terms of use cases, what does this mean? This means things like virtual primary care, which I'll talk about in a moment. It means behavioral health therapy, so therapy with a psychologist, or medication management for mental health disorders by a psychiatrist. It also means other chronic care programs, diabetes, hypertension, heart failure, cancer care, all sorts of conditions are now being addressed through the use of a telehealth-based intervention. So virtual primary care, this is an exciting one. There's a big move in the US right now to offer primary care services, so wellness visits, checkups, care for chronic conditions, all through telehealth. The hope is that you can receive that care from a known provider and that you can also see that provider in person when necessary. But for many patients, particularly patients with no known provider, this is an initial attempt to engage those patients and to get them preventive care for their chronic conditions. So what does that mean? It means a new software offering. It means an engaged and highly trained group of providers. It means new tools such as lab ordering and receiving, electronic documents completion and sick slips. It means the ability to make specialty referrals wherever the patient is throughout the country. And it means follow-up. It means continuity and ongoing care with the same known provider. And as we move forward, there are so many more exciting things. I wish I had more time to discuss. I'm very excited about chatbots and AI and remote patient monitoring, even pre-diagnostic remote patient monitoring with a watch or a ring or another device. But I think I would call out as something that's happening right before our eyes is enhanced home exam and enhanced digital integration. So this example shows a device called TitoCare. This device is a home, what we call tricorder, or a home exam device. It retails for somewhere in the region of $300 in the US. So while that's expensive, it is the type of price that is affordable on some occasions to help manage chronic conditions. This device allows a provider to see views of the skin up close. It allows the provider to see the eardrums, the throat. It allows the provider to listen like a stethoscope to the heart, the lungs, the abdomen. It really enhances the ability to examine, and it enhances the strength of the video visit. This is only one device. There are many others, but they really are changing what we can do in the home. And I would even highlight the other change in the home is the ability to do more point of care testing, more swabs and other testing in the home, dipping of urine samples, swabbing the throat for strep, swabbing the nose for influenza. This is another area in which we're seeing an explosion of new opportunities. So what does this all mean? As we look ahead, a large portion of healthcare can now be delivered virtually, which is very exciting. Also exciting, I would say, is telehealth is now a well-established part of healthcare delivery. It's recognized, it's paid for by insurance companies. As we look forward, deeper integrations will improve the patient journey and will improve patient outcomes. These integrations might be medical devices, watches, chatbot interactions with patients, texts, nudges, all sorts of new opportunities to gain information about the patient outside of live visits. And finally, new modern healthcare delivery models are emerging. I highlighted the virtual primary care, but many other models. We're seeing a blurring of the traditional model of an office setting, along with remote patient monitoring and disease management approaches, so that new models are emerging. And ultimately, we hope that these models will improve patient engagement, improve compliance with medication, and ultimately improve outcomes. So I'm going to stop there. I appreciate the time, the ability to present to you all today. I look forward to questions, and thank you very much.
Hello there. and thank you so much for this opportunity to participate in the 2020 Global Summit on Telemedicine and Digital Health. I really want to take this opportunity to thank Dr. Cordioli, as well as Dr. Klajner, to be able to represent Cleveland Clinic and to speak the subject of maintaining quality of virtual care during COVID-19. My name is Matthew Faiman. I am the Medical Director of Express Care Online here at the Cleveland Clinic, which is our virtual visit program. I'm also an internist in the Department of Primary Care, and I'm looking forward to speaking to you about something near and dear to my heart, which is quality care in virtual visits. Just a little brief background around the Cleveland Clinic is that our organization has been around nearly 100 years. We started back in 1921, and our mission to provide better care of the sick, investigating their problems, and further educating. It's very important to us, as well as some of our core values around quality. And so with that in mind, I really want to set the stage for the situation that was upon us back in the early part of this year, which was during pre-COVID. Our virtual volumes really represented only about 2% of our total ambulatory volumes. And even before our first confirmed case back in March, we activated a plan to scale up, which really included expanding telehealth privileges, expanding digital platforms, training and reorganizing the workforce, developing a telehealth playbook, and broadening communication within our teams. And with that in mind, this was the way it was, and this is what it sort of achieved, or what it led to, that by May of 2020, our digital volumes actually represented more than 65 to 75% of our total ambulatory volumes. Now, here we are in September. At this meeting, actually in October, I put these slides together. We're sitting around 20% of our total visits, which really is nationally, across the United States, certainly is a number that's consistent with where things are. Part of our key success factors really is the fact that we are an employed physician workforce. We did at the time establish an incident and operational command center, with which having something centralized really helped us to scale things up. We also had leadership support at all levels. We really found that communicating with our local and state leaders really helped. Developing training and support modules, which I will share some more details with, really made a big difference from a quality standpoint. And having great data to share and analytics really is very important. So how did we get there? Well, there are a few areas I'd like to spend some time talking about today, including expanding telehealth privileges, expanding our digital platforms, training and reorganizing the workforce, developing a telehealth playbook, and finally, communication with our teams. And without communication, I think that we realize makes a big difference in terms of culture. So quickly, just to mention around telehealth privileges, our legal team really helped provide some guidance for our qualified health providers and non-qualified health providers, such as dietitians, occupational and physical therapists, because we really needed to, be able to know who could do what and do when, especially keeping in step with federal and state relaxation of the licensure requirements. And these were and continue to be a moving target. And though it may be different, even where I grew up in Canada, there are different rules within provinces. There are different rules, obviously, here in Brazil among the different areas. Was here several years back, and I knew that there was a centralized approach to what the rules were around telehealth. Certainly in other places, you just have to recognize what the rules are. We also had some guidance from our leadership and finance teams to try and eliminate barriers to seek care for patients by reducing responsibility for COVID-related illnesses. So how else did we get there? Well, we had to expand digital platforms. And so what does that mean? Well, for us, that meant our synchronous and asynchronous and our remote tools had to be an option for our patients. We had to ramp these up really quickly. We expanded to all our institutes, including up to 4,000 physicians. And this happened really within a matter of 2 to 3 weeks. We offered solutions on several digital platforms, and all our patients were really encouraged to change all of their ambulatory brick and mortar visits to virtual e-visits for care at the outset of the pandemic. We still offer this to patients as an alternative, just to consider an option to remain socially distant as much as we can. And specifically to virtual visits, on-demand care workflows were something that we worked carefully towards optimizing. And part of that involved our Express Care Online, which is our white labeled app, which we've had in play for the last 6 years. We worked to that end, along with adding in telephone triage as an adjunct to manage the work queues. Because at times, to be honest, there were patients waiting for 2, 3, 4 hours to see us because they really were sick and they really had concerns, and we had to figure out a way to manage the demand, especially when there were major demands on the broadband and internet connections for patients. And we saw significant increases in volumes. So we also realized that there had to be other HIPAA-approved solutions when our go-to solutions didn't work, and those included FaceTime, Google Duo, and others. But when we saw 10, 15 times volume increase by mid-March, we also had to figure out a way to staff. That included training 350 providers from primary care, how to manage the queues. We created video and manuals to scale up new documentation templates. We standardized our virtual visits, our telephone visits, and our e-visits. We also wanted to figure out a way to track for COVID-19 related volumes, especially by creating smart data elements built within the documentation templates so we could actually do queries within the EMR. And these new workflows and new work pools were optimized just to help create some of that. But then with those new options and new work pools came new challenges, how to maintain quality. So just to step back for a moment, the quadruple aim, as we all know, is thinking about better quality outcomes at lower costs to our patients with a better experience for them. But we also have to have a better experience for the care team. So considering that and keeping that in mind, that's quality care really. And that's part of the digital transformation. And so the National Quality Forum back in 2017 considered very important areas around access to care, around affordability and availability, effective care, experience of the care being both by the patient and the providers, and then thinking about the cost and the financial implications. And so at Cleveland Clinic, way back at the beginning, when we started doing telehealth, we put that into play by taking guidelines, building templates, creating automated reports, doing audit and feedbacks of our caregivers, sharing those guidelines and creating new guidelines and putting that into a loop so that we could create benchmarks and provide performance improvements and gaps. And we actually share this with all our caregivers, and we continue to use that even as we scaled up. And that framework is key if you're going to create a program that not only can be used to build volume, but also build value. So we build competencies within education, both on the technology side, but also I will point out some things here around physical examination because I think it's important. Documentation templates, standardization of measures and workflows, as well as resources. So here's some examples, and I wanted to get into the granular just to point out when you're training providers on how to do things, it's important because many providers still have the mindset around taking a history, doing a physical, making an assessment, and making a plan. And some still query and question whether or not a physical exam can be performed. Short answer is yes, it can, and you should, and here's why. It's important around quality, and this has been supported by different national organizations that, quite honestly, accurate documentation helps for future care, especially if you have a baseline of care. And it's important, creates value for your patient and provider experience. And to be honest, in the United States, certainly reimbursement may be built around what gets done, what gets documented. And it may help around fewer missed opportunities later on. So some of these things are really, really important. And so some of the other things I want to point out is around some of the things around coaching. So these are some of the things we built out. You do little things like, can you hear me? Have you logged in before? What device are you using? What to expect during the visit? You walk your patient through the visit. You walk them through the exam. You get patients to participate in the exam. Having the patients self-palpate and actually get up and stand up and move around and have them, stand on one foot. Some of these things sound silly in some ways from what we're used to doing and what we've been trained as physicians. But when you actually get the patient to do it, they actually get that connection with you as their doctor, and suddenly they realize that maybe you're taking your time and they're now more relaxed because they're at home, and now you actually care for them in a different way. This makes for a better experience and actually helps the quality of what you're trying to deliver. Additional things like website manner, how you're dressed, how to be professional, how to look into the camera lens, how to make eye contact. And here, United States, about HIPAA appropriate space to conduct your visit. I always make sure that, patients may not choose the most appropriate place, like they're driving a car or they're at their office or they're on the beach when they, choose to see you, but you at least should choose your home office wisely. There are some additional things that we do here around documentation. We built out templates which helped our providers feel like they would be more confident in what they were doing. Just creating these documentation elements helped both telephone and for documentation. Here are some additional things. We built out videos on our own intranet that providers could also use on things like how to create empathy and how to use tips and tricks and how to perform a respiratory exam or a head and neck exam or a cardio exam. All those things seem now maybe in retrospect straightforward, but these are important things that when your providers have not done these before and they're very uncomfortable, that having these things available as a source that they can use really, really makes a big difference around quality. We even created dot phrases within our documentation electronic health record. And when you just see this here, I don't need to get into the details, but there's a lot of physical exam you actually can do virtually and remotely. And when you do it, you realize that you actually can do a quality, detailed physical exam and physical assessment of your patients. We even went so far to create some tools within our iPhones so that providers could actually figure out how to bill appropriately and how to have these at their fingertips so they wouldn't be struggling during the visit. So the situation on how we finally got there, we did train, we reorganized our workforce, we developed a telehealth playbook, we figured out a way to communicate within our teams. And so what did it get us and what did we achieve? Well, ultimately, at its peak, our digital volumes, as I said before, represented more than 65%, 75% of total volumes, which equated to more than 200,000 scheduled virtual visits and roughly 15 to 20,000 on-demand virtual visits on a monthly basis. We had also about 3,000 asynchronous visits at the same time. And so we are now living in our new normal with a steady virtual visit volume. We have a quality framework in mind. We are sharing this with all departments and all teams, and they're actually applying it to their own areas. And we are following carefully for things like antibiotic stewardship, alignment with and concordance with guidelines. And this has helped us across all areas to be actually more mindful of how we are caring for our patients. I really appreciate the opportunity. I really wanted to share some best practices of what we're doing, where we've come, the journey we've been at. Also, I'm looking forward to some robust questions and answers here, and I'm looking forward to a further discussion. On behalf of everyone here at the Cleveland Clinic, I thank you for the opportunity to speak, and I appreciate the opportunity. Thank you very much.
Olá, obrigado por estarem com a gente no Einstein Talks. Nós estamos numa sessão falando de crescimento exponencial da telemedicina e manutenção de qualidade. Sem dúvida nenhuma, todos nós que trabalhamos com telemedicina passamos por um momento, no começo da pandemia, de alta demanda. E tivemos dificuldades, principalmente tecnológicas, como quedas de servidor, tempo de demora, delay para fazer a conexão, porque ninguém no mundo estava preparado para esse crescimento exponencial, essa alta demanda pelos serviços de telemedicina. Mas rapidamente conseguimos ajustar a quantidade de servidores e conseguimos dar uma resposta tecnológica adequada. Eu vou compartilhar com vocês alguns dados aqui do Einstein sobre como nós fizemos para fazer a manutenção da qualidade face ao aumento da demanda. Eu vou compartilhar minha tela agora. Bom, sem dúvida nenhuma, começa a pandemia, né? Aqui, no começo do ano, nós estávamos fazendo cerca de 60 atendimentos por dia. Esse é um histograma, né? Onde cada barra azul dessas representa o número de atendimentos diários. Nós estávamos fazendo 60 atendimentos ao dia na nossa telemedicina, na linha de serviço de casos agudos não complexos, né? Telemedicina sob demanda, né? Na nossa UPA digital, estávamos fazendo cerca de 60 atendimentos por dia. Começa a pandemia aqui e nós passamos, né? Começa o coronavírus e nós saltamos de 60 para 1.000 atendimentos por dia em um pouco mais de um mês. E aqui é muito interessante, a primeira observação é que a linha laranja é o número de casos relacionados a coronavírus, de síndromes gripais. E a linha vermelha são os números de casos totais. Tá? Notem vocês que começa o crescimento, começa a pandemia, o número de casos totais e relacionados a coronavírus cresce em paralelo. Quando chega lá na metade de maio, o número de casos relacionados a coronavírus se mantém estável e o número de casos totais continua crescendo exponencialmente. Mostrando que, num primeiro momento, nós fomos acionados muito por causa de casos relacionados a síndromes gripais, possivelmente coronavírus. Mas depois o paciente descobre a telemedicina e continua a nos acionar, mesmo quando não está relacionado a síndromes gripais. Mas será que foi o coronavírus que me fez crescer exponencialmente? Sem dúvida nenhuma, ele me fez crescer. Mas notem, nós no Einstein começamos a fazer telemedicina direto ao paciente, pronto-socorro digital, em 2017. Em 2017, nós atendíamos um paciente por dia. Em 2018, 2 pacientes por dia. Em 2019, 4. E em 2020, passamos a 60 atendimentos por dia. Isso dá um índice de correlação de 0,87. Ou seja, eu já estava crescendo exponencialmente. Chega a pandemia, eu passo para um índice de correlação de 0,90. Exponencialmente, 0,03 faz diferença. Mas eu já estava crescendo. O coronavírus impulsionou esse crescimento. E esse dado bate com essa publicação da AmWell, né? Nós temos o Peter Antall, da AmWell, falando hoje. Esse é um dado da empresa dele, que fez uma pesquisa que mostrou que 64 milhões de americanos já trocariam de médico por um médico que oferecesse consultas por vídeo. 64 milhões de americanos. Isso em 2019. Senhores, essa é uma sala de espera de um hospital público. Ok, esta é uma sala de espera de um hospital privado, olha que bacana. Mas nada supera o conforto e a segurança da sua sala, do seu lar. Senhores, a telemedicina tem essa capacidade de melhorar a experiência de forma absurda, quando a gente compara com outras possibilidades. Quando a gente melhora a experiência do paciente, a gente aumenta o acesso dele à saúde, nós conseguimos melhorar a aderência. E quando a gente melhora a aderência, a gente melhora o desfecho. Tá? E nessa linha de pronto atendimento digital, né, onde nós fazemos uma teleorientação, nós não fazemos acompanhamento de crônicos, nós não fazemos consulta especializada, nós não fazemos prescrição de drogas de uso contínua, nós não fazemos laudo nem segundo opinião, nós não pedimos exames, a gente não faz retorno. É uma linha de serviço de teleorientação. Tá? Nós já atingimos mais de 1.200 cidades, espalhadas por todos os estados brasileiros, e providenciamos acesso a quase 2 milhões de brasileiros com acesso à nossa telemedicina. E 92% deles não têm acesso ao Einstein. Então, a telemedicina foi uma forma que nós encontramos, sim, de quebrar barreiras e poder levar Einstein para todos os brasileiros. Agora, como é que eu consigo fazer a manutenção da qualidade e faço um aumento da demanda de forma abrupta? Senhores, é uma mistura de processo com data science, big data. Tá? Nós temos um processo muito bem escrito de recepção e treinamento de médicos, protocolos muito bem definidos. Então nós fazemos o processo de onboarding, onde o médico ele é admitido na telemedicina e treinado. Lembro os senhores que nós no Brasil não temos aula de telemedicina na faculdade, tivemos que aprender e temos que ensinar nossos médicos que vêm trabalhar com a gente telepropedêutica, como fazer escutativa numa anamnese feita à distância. Então, o ensinamento da telepropedêutica, que é usar gadgets para fazer exame físico à distância, tem que ser aprendido na admissão. Então, fazemos um processo de onboarding, treinamento, monitoramento e damos feedback para esse médico, de forma contínua. Então, no processo de onboarding, primariamente é feito um checklist técnico, onde nós fazemos o certificado digital do médico, cadastramos esse médico nos sistemas, explicamos quais são as etapas de atendimento, como preencher os campos, e ele aprende testes e senhas para aprender a usar o sistema sem falha nenhuma. Depois que ele aprende a usar o sistema, nós fazemos um checklist clínico. Ensinamos protocolos e condutas, falamos sobre o padrão Einstein de qualidade de atendimento, ensinamos telepropedêutica, explicamos quais são as situações de exceções e como lidar com problemas, como resolver conflitos, que muitas vezes o paciente quer um atestado, quando não tem indicação, ou quer um refil de receita, que nós não fazemos, tá? Refil de receita de uso crônico, né, tem que ser acompanhado pelo médico que está fazendo acompanhamento desse paciente. Nós fazemos a nossa linha de serviço para casos agudos não complexos. E aí, o médico, ele começa, ele não vai para o atendimento direto, ele observa o médico sênior, o médico instrutor atendendo. Depois de observar atendimentos, aí ele vai começar a atender, sob supervisão direta do sênior. O médico sênior observa ele atender. Depois que ele atinge os critérios de qualidade, o médico sênior libera ele para o atendimento solo. Tá? E ele recebe esse médico todo mês, tá? Ele recebe a sua produtividade comparada, ele recebe um informativo sobre a qualidade dos seus prontuários e a gente vê aderência a protocolos, baseado em um algoritmo de linguagem natural que nós desenvolvemos dentro da telemedicina do Einstein. Essa é a carinha do módulo de recepção de informação da sua prática médica que todo médico recebe todo mês. E nós fazemos esse feedback do nosso coordenador médico com cada médico continuamente, todo mês. E nesse feedback, o médico referência passa as estatísticas, dados e recomendações para ajuste da sua prática para cada médico, e o médico também faz uma avaliação 360 graus, dando para o médico referência insights que nós poderíamos melhorar no atendimento. Dessa forma, nós conseguimos garantir a manutenção da qualidade, senhores. Isso é perceptível. Notem, os senhores, aqui está o nosso NPS, o Net Promoter Score. Ele se mantém estável. Na linha cinza é 2019, na linha azul 2020, e nós estamos com o NPS acumulado no ano de 76, no mês 79 em julho, agosto foi o NPS de 80, mostrando que a gente consegue manter a qualidade de forma linear, mesmo com o aumento do número de atendimento. Além disso, como é que nós conseguimos ajustar a questão da espera? Nós fazemos simulação de Monte Carlo para filas de múltiplas entradas, onde nós verificamos o fluxo de demanda, a variação do tempo de atendimento, o número de atendimentos por dia e o número de médicos. Com isso, nós criamos simulações, onde várias simulações no dia, nós calculamos o tempo de espera e a probabilidade de passar de determinado tempo pré-estabelecido. E aqui, dando um exemplo para vocês, esse é o extrato da simulação que nós fazemos ao vivo. Então, nós simulamos aqui 1.000 atendimentos por dia, a gente tem um tempo médio de uso do médico de 13 minutos por consulta, tá? Nós temos uma escala que cobre 285 horas, esse cálculo foi feito em junho, tá? Nós tínhamos uma espera média de 2,60 minutos, a probabilidade de espera acima de 10 minutos de 6,81%, probabilidade de espera maior do que 30 minutos de 0,68%, uma ociosidade média de 16%, uma produtividade média de 3,5 pacientes por hora. Se nós acrescentamos 30 segundos no processo de atendimento ou caímos 30 segundos pela diminuição da produtividade, olha só, o tempo de espera aumenta para 3,63 minutos, que dá mais 45% de tempo de espera média. Aumentamos acima de 30 minutos, 51% de aumento em perdas acima de 30 minutos, de perder o paciente. Tá? Então, criando essas simulações, e aí a ociosidade média, ela sai de uma ociosidade média de 16%, ela cai em 13%. Quando você tem pouca ociosidade no sistema, você aumenta o erro e o burnout. O sistema, para ser estável, você precisa ter um cálculo de ociosidade médica adequado para dar tempo para o médico respirar, tomar uma água, um café. E nós trabalhamos com a ociosidade média alvo de 15% do tempo. Tá? Em 15% do tempo de contrato do médico, nós queremos que ele relaxe, que ele dê uma respirada. Abaixo de 15%, a gente acredita que a gente está entrando no risco de burnout. Então, a gente mantém esse cálculo de filas de forma contínua para fazer ajuste de forma linear na escala, e a gente consegue. Aqui, por exemplo, fazer a manutenção, vocês estão vendo, passa dia após dia, esse é o tempo médio de espera, né? A distribuição da variabilidade do tempo médio de espera. Notem vocês que praticamente não há diferença estatística da mediana dia após dia, fazendo desse jeito essa manutenção da escala conforme a produtividade / número de entradas. É isso que eu tinha para falar para vocês. Muito obrigado. E nós vamos agora ficar para o debate, onde podemos conversar nesse endereço que vai seguir agora.
Professor Antall and Professor Faiman, thank you for being with us in this conversation, in this panel. It's an honor to be with you as an organization that we have a lot of how to see as a benchmark in terms of telemedicine, in terms of population health. I, by myself, I've been in Cleveland Clinic so many times in digestive surgery and colorectal surgery, also department, but together with the management also. But I would like to ask to you, both of you, how did you deal with some kind of doctors that we have? I think we had in the beginning the same problem. We had a very traditional way how to graduation to form physicians, and how autonomy can impact in terms of the outcome of the patient in the brain of the physician of all the generations. So now we are bringing something that could bring another opportunity to deal with challenges with the some barrier, the logistic barriers, for example, but something that there is a preconcept or physicians that avoid, that don't know what this kind of relationship, virtual consultancy, virtual telemedicine, how they can embrace this opportunity. And here in Brazil, we have this problem also, so that we have a regulation that is very, very old. So I want to hear from both of you how we could engage physicians in terms of adopting and using as a way of reach their patients. Thank you very much.
Yeah, Matt, would you like to start?
Sure. So thank you. And again, I appreciate the opportunity to be here and represent Cleveland Clinic, and in fact, just represent telehealth. And it's something that's passionate, or that I'm passionate about. I think, COVID brought to light or sped up the fact that we had to start doing this. Peter and myself and Eduardo and others have been doing this for some time, and so we all knew what the value was. And so knowing that, there were a lot of different elements that we kind of think about. We know that the on-demand, the patient-driven episodic care is an easy way for engagement of even providers, clinicians, physicians, getting them into the game. But that's coming from the consumer. I'm sick, I need something, I want this. It's transactional almost, and it's done. But it's a way also to inform the clinicians that you can deliver a product not only for these acute visits, I'm sick, I think I might have COVID, I might have the flu, into a continuity of visit of chronic care. And COVID illustrated and demonstrated the fact we had to do this. Like, patients weren't comfortable coming into my office anymore, and they're like, well, how are you going to take care of me? Figure it out. And so we had to, we suddenly had a bandwidth problem, we couldn't get them in the physical office, and so we suddenly had to ramp up training sessions. And then we had to get the fact that we had these playbooks, and we had ways to train physicians and nurse practitioners and everyone, we can do this, and you can do a physical examination, and you can deliver quality care, and you can do this, and we had to do it quickly. If I had time on my side and could go back in March, I might have done it a little bit differently, but we had no choice. But we had support from leadership. We had some legal changes that made it more capable for us to do. And we had the buy-in from the patient. And so the patient sort of voted with their feet saying, we want this. And so the clinicians were like, please teach me how to do this. And so we're on this journey now towards delivering it to the patients. I know there's a lot of things in there to talk more about, and I'll let Peter add some coloring, and we'll continue the dialogue.
Yes, thank you. And it's a great question. And thank you for the opportunity today. This is wonderful. We do a patient survey and a provider survey every year. And so I can cite from that survey on the provider side, 72% of providers say that technology challenges might be a barrier for them engaging in telehealth. 62% say uncertainty about whether they'll get paid or get paid the same amount for the same visit. And 57% expressed concerns about the clinical matters, how to properly conduct a visit in this way and make sure that the patient is well cared for and safe. There were a few other minor ones, but those were the major barriers that providers cited in our most recent study. Those numbers are improving. They actually were worse in the past. I think 62% I said are worried about being paid this year. Last year it was 77% worried about being paid. So, the numbers are coming around. And I think, to go back to the initial part of the question, I think the good news is that the younger physicians in training are on their technology all day long anyways. This is a normal part of their life. Many of them now were born after the internet became a thing. And this is normal to them. And so I think that we try to encourage adoption by showing providers that this is, in our view, not a different specialty. This is not some specialized part of healthcare. This is just another tool that you can use to provide good care to patients. And it's not a tool for every visit or for every condition. It's one tool in your toolbox that you can use. For example, if I'm seeing a new patient and I'm doing a yearly physical, I would be best served by bringing them into the office and spending the time and doing a full exam and ordering labs if needed and those things. However, when I see that patient 3 months later for a check-in on their hypertension, as long as I have readings and as long as I can meet with them by video and discuss their medications and their side effects, there really isn't a great reason why I can't do that visit by telehealth. And we're seeing in our practice, in our business, a big shift from on-demand urgent care visits to scheduled follow-up visits. And that's one of the notable changes that has occurred since COVID. Because of COVID, so many providers who have an office have now engaged in telemedicine. Now that their offices are open and back running, there's still many of them doing visits like I just described through telehealth, because they know it's not necessary for the patient to come in. They know that it's more convenient for the patient, and there may even be efficiencies in terms of the visit being shorter and less need for staff that even help save costs. So, we're finding it has been a slow journey to get providers engaged, but now that COVID hit, that journey has been sped up.
Thank you very much. Thank you very much. I think it's more or less the same every country. So, Cordioli, I think you want to say something.
Yes, it was a pleasure to receive you, Peter and Matthew, live here on our Einstein Talks. And we sure next year we will have a live in-person event, and you are both invited as well to be with us on 2021. And I have one question from the audience about the back office of telemedicine, because they are saying, the person who are asking the question are saying that some patients have difficulty to access the platform, to deal with the platform or access the service. You, in your services, do you have some kind of reception that helps the patients to be ready for the consultation, or the patient access directly the doctor, or the patient have the opportunity to first have a reception that receives the patient and put the microphone, works with the camera, put the patient correctly to have the digital consultation with the doctor?
Yeah, maybe I'll go first on this one, Matt. I know you have some interesting things to share at Cleveland Clinic. From my vantage point, I see what happens at many different hospitals using our platform. And what I would say is I've seen many different models. Some organizations use a nurse or medical assistant to virtually room the patient before the doctor comes in. Others allow the patient to go directly to the doctor. Some organizations have their own support team, a telephone support to help if there's technical problems. Others lease that support from our company. We have support teams that can help a patient if they have technical problems. I think what I would say is that you do need some support, and I'm sure, Eduardo, you've seen this in your experience. You need some support for a telehealth program, but the support you need is a little bit different than the support in the brick and mortar office setting. You may need a little more technical support, but a little less nursing support, for example. It also depends upon your use case. If you're doing scheduled visits, you may need some help with patients making appointments. If you're doing on-demand care, you may not need that scheduling support. So it varies. I think the best advice I have for anyone developing a new program is take the best of what works from your existing brick and mortar staff, but understand that they will need to perform new functions if they're supporting your telehealth program.
And so I'll add, so just like Peter mentioned, we have done surveys on both the physician, clinician side and on the patient side. And surprisingly, 5 years later or more, technology challenges still remain to be the biggest, barrier and problem for patients. And it's top problem all the time. So we're still trying to figure out the best ways. So we and we're like many other academic medical centers, we actually have sort of two methods for which patients can access our clinicians for telehealth care. We have sort of the on-demand version, which is driven right by an app. So a patient comes in, downloads the app. They do most of their tech checks themselves, so they can, whether they're using an Android or an iPhone or a PC, webcam, etc. They do most of that themselves, and it's actually easier. They go into a virtual waiting room, and then they see the provider. So it's easier in some ways. We need less support for problems, whereas with our scheduled visits, there's value because we're using our electronic medical record as the patient entry. So patients can fill out questionnaires, they can upload pictures, they can enter their insurance information, and then they can connect with us. But it also is a source of problems because the handoff is to the actual video connection, and sometimes we've used Zoom, sometimes that didn't work. We have another option. We work with AmWell, and we've had a great relationship with them forever. And so when things fall apart, we've had to figure out, what do we do when, like, if Dr. Faiman is running 20 minutes behind, how do we notify the patient to sit tight? They get very bored. And like you commented, Eduardo, when you have 3, 4, 5 minutes of wait time for patients, they get really impatient in the virtual rooms. They're multitasking themselves, and they'll really dismiss. They'll call the office and say, where's Faiman? Where's Faiman? What's going on? So we have to then text our medical assistants, call the patient, say Faiman will be there, just sit tight. And so you have to have those issues set up so that you know how to make things run smoothly. And you also have to make sure when the patient doesn't get the technology downloaded and they haven't figured it out, that you have a backup. And the backup has to be a video solution, a phone solution, some solution so that you can have a meaningful appointment, because once I'm behind because of one problem, then I'm behind for the next 15 patients for the day, and everyone gets upset. So it's important to have some structure so that each office and each facility knows what they're doing. And we've obviously put some thought into this, but what I say and what happens in reality, it doesn't always work out like I hope.
And one other trick that I would add is I've seen this at a few institutions, I think including maybe Cleveland as well. If you want to get providers happy and engaged and enjoying their experience, some organizations have someone from the technical team room the first 3 patients and make sure everything's working, the audio, the video, they're connected, and then the provider comes in to see the patient. What that does is it gives the provider 3 chances at a perfect experience. Everything's working, everything goes well. And they don't have to get bogged down on their first or their second visit with a technical problem. And so I think that's just one maybe trick to get providers who are skeptical to try this and have a good experience.
Right, and I know there's lots of questions. We do what are called test visits, and I think it's critical to make sure, whether it be see one, do one, or have the senior person watching someone else do it, but make sure that you have someone make sure it goes off without a hitch, because then once they've done, as my former boss said to me, if you do 5 or 6 of them and they go well, you're in love, you're married, you're going to fall in love with the technology and forever want to do this. But if you have bad experiences, you probably are going to not want to do this again. So if you make this run smoothly, it's a hit. It's a home run.
Yes, here in Albert Einstein, we have that we call a digital concierge that receive the patient, test the camera, test the sound, and put the patient in the front of the doctor, navigates the patient until the patient are done. They are dealing with technology. Sometimes they get some exams, some digital exams, some images of the exams of the patients, and put all together for the doctor to perform the consultation. We are able to show for our leadership that doing this way, we can spend less time with the doctor, and the price of the time of the doctor is far more expensive than the price of the time of this personal concierge. So this is what we are dealing with, this digital literacy. Like how can I say digital literacy? I think that word is correct.
Yeah, that's right.
I improved my English. So,
very good.
Thank you. Thank you.
Great.
So we are improving this way. We have another a question here in the audience, and I do for you both. In the beginning of the pandemics, I think all the institutions of telemedicine faced some time of struggle with the technology. The servers go down, the video consultation suffer a lot. And did you use anything besides a official platform? What was talking that in the beginning of the pandemics, all of the telemedicine services suffered some kind of interruption of principally in the video connections. And in Albert Einstein, we use a solution that, an official solution, but some of our doctors started to work with WhatsApp, FaceTime, everything, they go wild. And in your opinion, it's possible to go wild with telemedicine. Okay, I am using now FaceTime, I use WhatsApp. What do you think about this?
Well, so at the end of the day, as Peter commented earlier, telemedicine was a tool to deliver care, and we really needed to care for our patients. So we really needed to get the care to the patient, and sometimes, a telephone call would be sufficient. And, we provided as many tools. Like I spent many sleepless nights talking to our leadership and our legal to make sure that under the federal rules and under the Health and Human Services and Centers for Medicare and Medicaid, et cetera, that we had at least some guardrails, like these are your official rules, these are the expanded rules, these are acceptable. And if you're going to use an alternative like that FaceTime or Google Duo, or these are ones that would be acceptable as a backup, but don't get too much in love with them, because they when the epidemic or the public health emergency goes away, we are going to have a permanent solution that you're going to have to use. But we really had to figure out a way that we could provide guidance to our caregivers to say, you can use this, but, just don't use it as the primary way, because, like when I mentioned before, if you're using our electronic medical record and we get information about your depression score or your insurance information or whatever, if you now just FaceTime every patient and you go around the whole system every time, now you don't do tech checks, and now you don't do all these things. Like, we're losing lots of relevant things here. And now we get off track of capturing like the patient's demographics and all these other things. So we tried to hardwire and write like a playbook of what to do and what's acceptable, and then we have to update it and say, now don't do this, or only use this as an emergency. But we had to provide a tool until we could get patients back in the brick and mortar office. And so it definitely was unnerving and scary, and thankfully we had some some guidance about what to do. So, Peter, other thoughts?
Yeah, I was going to just add that, we have the HIPAA regulation in the United States that governs patient privacy with regard to medical information. And many of these technologies don't meet that criteria. They're not HIPAA certified, like FaceTime and others. It has to do with either how the data is transmitted, where it's stored, how it's stored, who has access to it, your security. That HIPAA regulation was waived during the pandemic because it was an emergency, and that allowed, as Matt said, that allowed doctors to use FaceTime and any sort of chat, WhatsApp, anything they want. That regulation will be reinstated once this emergency period is over. And so that's one sort of guide that, in general, outside of an emergency situation, providers need to use technology that meets certain privacy standards. And so we expect to go back to that. The other problem I would add is Matt mentioned quite a few other reasons why you may not want to use technology like this if it's not tested and it's not part of the normal workflows. It's not documented in the record. But one other practical problem, if a patient has your WhatsApp or your FaceTime number, they can call you anytime they want. And so a lot of our technology is to create a brokerage between a patient and a provider that is more formal, so that they can't just dial you up when on your personal phone when you're not working.
Yeah, and it's funny. I spent as much time trying to figure out how to show my doctors and others how to block your number if you're using FaceTime, and how to things. I'm not sure what they do in Brazil for FaceTime or WhatsApp, like how to block it so that I wasn't always at the mercy of my patients having my information, either my email or my phone number, so that they could call me at every hour saying, I saw you last week. I'm now again not feeling well, and now I'm, I want to just reach out, and I'm like, oh dear, I'm eating dinner. Like, this isn't a good time. So there was a lot of that we had to get around, and I was in the same, I was dealing with the same as everyone else. I'm like, this is why we want to use sort of a HIPAA acceptable technology, so that we protect the privacy not only of our patients but of our doctors too, so that they have a life, so they don't burn out.
One other nuance in the United States is sometimes there are requirements for use of an acceptable technology in order for an insurer to pay you for the visit. And so that's one other reason that providers might choose certain technologies. In the United States, typically insurers won't pay us for a normal phone call with a patient, even if we spend 15 minutes, because it's not documented. They don't have access to the record and proof that the phone call occurred and things like that. So there is a payment part of this as well.
Thank you very much for the answer. I think that we have the same thoughts here in Brazil. The thing about using unofficial tools to work is that you are going to use your personal number. It's not so safe, and you cannot share to put the information in our EMR. So it's why we defend to use official tools, and if you have any problem, please call the technical support, and we will solve it for you. And we have a nice question for the audience talking about the use of nurse staff. Before getting in contact with the doctor, if you guys in the United States, Matthew and Peter, do you have any experience to use nurse to try to triage the patient before the initial consultation with the doctor from the on-demand care, on the acute on-demand care?
We have and we haven't. We probably have spent more with scheduled triage, especially for specialty. For the on-demand side, we found that intake questions, almost like an asynchronous visit, pre the synchronous visit, has been more utilized. Having someone do a triage, it's actually happened where they call the office, or they reach out in the electronic medical record, or they fill out like we have what's called a COVID e-visit, and they fill out a structured questionnaire, and it says, you have symptoms suggestive of COVID-19, you may need a test. Click here to start your virtual visit, and they click and it takes them the URL right into the app and they start the visit, because we need to have a virtual visit to make sure they're not like toxic, sick, septic, or anything else, that they need a higher level of care, and then we can order the actual testing for them in our local area. And so we found that adding in the nursing, though it may help, we found that more often than not, it just usually the nurses will have triaged the patient in some other capacity via them calling the office, reaching out, and then the nurses now know, thankfully, through the last 6 months, that they can just point them directly to virtual care, saying, you are sick, it seems like you need to be seen, here is your options. Now it's walk in to be seen in the office, we'll schedule you, or more importantly, click, download the app and be seen right now. And the patients are like, oh, okay. So they've been empowered to start doing this. Whereas, a year ago, they don't know what the options are, and they would just point them to the emergency room. So we've seen a decrease in emergency room utilization, and now much more utilization. So it's not, if you're asking, like, do we see it? Nurse sees patient, triages them, and then puts them right in our waiting room. It doesn't happen exactly with that handoff, but it's close, and it's noted in the chart so that the patient then hands off and sees us. So we see all of the triage documentation.
What we've seen, many of our hospital system clients use nurse triage. They might have it on site, or they might contract for an outside nurse triage group. But the trend seems to be moving away from use of nurse triage, as they can be expensive, to using chatbots. Now, the nurse triage in the U.S., the most common guidelines for nurses doing triage are the Schmidt-Thompson protocols, Barton Schmidt and David Thompson. And what they've done, what others have done, what we've done as well, is to take those protocols and to create chatbot algorithms where it is an electronic bot asking the same questions. And there are occasions in the logic in which, if the patient says they're experiencing an emergency condition, they're sent immediately to the emergency department. But what we like about the use of a chatbot prior to a telehealth visit is there is an element of safety here. So if the chatbot misses a serious symptom and the patient is quite sick, in the end, they end up, most of the time, if they're not sent off emergently, they end up seeing a clinician anyways. And now that clinician has more information, can dig in a little bit and ask some additional questions, and either care for the patient most of the time, or occasionally, if a patient slips through that's sicker than average, they can still make that referral if needed. So that's a real trend. And I would just add, we use nurses post-visit to coordinate care or coordinate referrals, but even that area is beginning to become disrupted by bots and other technologies. The big trend right now in healthcare technology that we're seeing is nudges of patients. Nudge like little light elbow to nudge somebody. And really, nudges they can happen in a variety of interfaces. It could be a text message. It could be a message through your app. It could be a beep on your phone. on your watch. But nudges are really an attempt to remind patients when they're not in a visit of the plan, to check that they're taking their medication, to make sure they're measuring their blood pressure if they have hypertension, and things like this. They're even, I think there's a lot of progress on nudges for patients with mental illness, to make sure that they're doing their daily activities as recommended by their therapist.
Both of you in your answer talk about chatbots. Our experience with chatbots and some automatic triage is not so good. The patient wants to talk with someone, and if he starts to put the finger on the phone and never get someone to talk with him, they drop the call and say that this don't work. I want to see someone right now. They go to our emergency room. So we stopped to using chatbot and some kind of automatic triage. And in your experience, you are using chatbot, or even I know about Babylon. I think everyone knows about the Babylon initiative to use chatbot before to the patient to get someone to talk to. So in your experience, the use of chatbots is a good thing to add to the patient journey, or the patient don't like it at all? What do you think about it?
I think you raise good points. I think that chatbots are not the answer for everything, but I think the experience that I've had so far, and I also advise a chatbot company in San Francisco called Giant, Gyant, which is doing some good work, and I think they're working, I believe, with Cleveland Clinic. It's not for everyone. It appeals more so to the tech-savvy younger patient where they want to save time. They don't want to be bothered having a doctor visit. So you have to know that it's only operative for certain patients with certain needs, in our opinion, or in our experience so far. We also, because of, Eduardo, exactly the sentiments you expressed, somebody who's coming in for a telehealth visit, they want to talk to the doctor. And so what we did there is we inserted the chatbots simply in the waiting room. And the goal there is documentation support, gathering data like a nurse or medical assistant would, knowing that ultimately it's just it's basically to keep them busy until the doctor's ready. And then it keeps them busy, the doctor gets a little bit more data, and ultimately they have their live visit. So I think in the end, I see the chatbot being more of a navigator, pre-visit, post-visit, nudging them about reminders in the future. I think, a unified voice. We call our chatbot Amy, A-M-I, and the reason we did A and I is AI is built in. We thought that was a nice joke. But we see her, Amy, as somebody who will help a patient in their journey, whatever that journey is in the future. Some of it may be a journey into a visit. Some of it may be a journey post-visit or at other points.
Yeah, I agree. As someone who has played around with sort of versions of this, I have found that it's often feels flat, like it's like what it seems like. You want it to be more of an experience like other things. If you're using technology that you as the user, that you feel like there's some, like you win or you get something, or there's a reward when you get your outcome. And honestly, sometimes patients want something else. Like they want to know, maybe I do have the flu and it's mild and I can just stay at home with some chicken soup and fluids and it's going to go away. But other times they want something else. Like if they want their sick note, then this isn't going to get them there. And so they'll keep like backing out of the system and keep changing their answers until they get what they want. And so we have found, like, we had a version where we couldn't track patients doing that, and they would finally hit us with the answer that they wanted to get, and then they still would have to see us. So we now have an ability to track how many times they use the system, and it would make a recording, and so we would see them change their answer. Do they have fever? Yes. No, now they don't. Yes, they do. Do they have flank pain? Do they have hematuria? They keep answering differently until they get where they want the outcome to be, that yes, they do have a UTI, and yes, they do want antibiotics, because before they weren't getting the right, answer or outcome. But to Peter's point, I think if someone's like being remotely monitored and getting, information pushes or nudges and pulls and getting feedback like, how are you feeling today? Are you having new symptoms? Are you exercising? If they get enough alerts and then it triggers like an alert back to the team that maybe they need to be seen because they are having a flag, a yellow flag or red flag to the providers that are watching them, the nurses, the doctors, the educators, the coaches, that now that AI chatbot is doing what it's supposed to, and the patient sort of feels like they're much more engaged to the team, then you've sort of met your goal of what the chatbot does. And then the only other way I think chatbots have a value is like triage. If it triages your healthcare team or your health system to better manage who needs to go where, then the chatbot might serve a purpose. And so we worked with like Giant or Babylon or others to say, if you use it as a tool to help triage so that the patient now has 1 or 2 or 3 more options for what they need to do, then you might save them going to the emergency room or going somewhere else or going to a higher cost of care, especially in the United States. We have these contracts, and we're a health system we're on the hook for these accountable care organizations and these patients that we're responsible for. We don't want them to go to the emergency room if we don't have to. So if we can share with them to do this or not do this, then the chatbot might serve a purpose.
And one other point I would add that is intriguing about the AI part. When you have a chatbot and you create an AI feedback loop on an outcome, amazing things can result. The amount of data that they can compile, and the example of Giant, and you all know this virus unfortunately too well, the Zika virus. Giant started by offering a free symptom checker for Zika virus back when that was prevalent. And what they then did is they gathered data on test results. When a patient was recommended to get tested, they gathered data on the test results. And when you create a feedback loop, you could then train your AI to ask more questions or less questions, or to know which questions are most meaningful.
And we have a last question from our audience about recording the teleconsultation, the televisits. I know about the HIPAA compliance standards that don't recommend to record the visits, but our Federal Board of Doctors of Medicine state regulation that they say that you must record the televisits. So in your opinion, what do you think about recording the visits? In advertising, we did not record the visits.
Yeah, so I can be short on this one. I mean, we don't have, I think, the bandwidth. My bandwidth to record my presentation today took up way too much space. So, and it was difficult, packaging it up, putting it in drop boxes. So I can only imagine what it would do to our health system, probably corrupt the whole system if we recorded them. But so practically speaking, it's difficult. And we look at it sort of like, what do we do in the brick and mortar, face to face? We don't record sessions there, so we wouldn't think about recording them in some other way unless we had some sort of sensitive examination that we thought, we needed to have some recording. We usually get a chaperone or something. We don't worry about that any differently in telehealth. We probably have some different rules. We feel like it's not necessary to record them. We might store and forward, like if a patient has a good, rash, they want to record, get the picture to us. That we are happy to put in the record, but the actual recording of the interaction doesn't seem like we need to do it at this point.
And we agree. It's an incredible amount of data, number one. And number two, in the U.S., we do have some rate of malpractice suits. We have some people who don't like their care and they sue. And we worry that a real good lawyer could find one word you missed or one word you said just confusingly in order to support a case of malpractice. So we worried that it might create more liability than it would help. And we have the same basic belief, as Matt said, that we record our notes just like we do in any other setting. I will add, though, that we have been exploring from a documentation support perspective, there are now really amazing natural language processing programs out there that have gotten good enough that their reliability is nearing 100%, and they're now getting good enough at putting information. They know which speaker said which word or sentence, and they can put information that is said in written word into boxes like the history, the medications, the allergies, and help you then document your note at the end of the visit. So we're exploring this. We find this very interesting. In the end, we wouldn't probably keep the recording, but would use the spoken natural language processing in order to help our documentation.
So, thank you, Peter. Thank you, Matthew. We sure in 2021 we'll be together again in person here in Brazil. So it will be an honor to receive you here. And thank you for your time. I know that you have a busy agenda now. Peter, you have just did an IPO in your institution. Matthew is growing. I think that the digital visits on Cleveland Clinic is growing bigger and bigger. So thank you for your time. I appreciate that. And next year I ask you to come to Brazil, and we will receive you here with all the honors that you deserve. Thank you very much.
Well, thank you for the invitation, and I would love to come visit with you all. It would be an honor for me, and I would assume Matt as well.
We'd love to come back to San Jose. We had a wonderful time, and I would love to come back. So I appreciate that. It's an honor to be part of this meeting. So thank you, everyone.
Thank you very much. Bye-bye.